So today let's discuss about the physical examination of respiratory system. So like in all system examination, here also there are four headings, that is inspection, palpation, percussion and auscultation. So we do physical examination after thorough case taking, and we might be having some idea about some particular disease in that patient. So to confirm or differentiate it between different conditions, we have to perform physical examination. That is the purpose of physical examination. So first of all, we can start with the inspection of respiratory system. What all headings or what all things come under inspection? There are few things we have to observe in inspection. In inspection, we are actually observing the patient. We are not touching the patient. But when we touch the patient, it will become palpation. So it's the first phase of physical examination. We are just seeing the patient or observing the patient. So the most important or the first thing we have to note is the skin over the chest. That is not for the color changes, visible swellings, if any, like lymph nodes or any contusions, any color changes we have to note in inspection. Then look for scars, previous surgical procedures, if any, in the chest, like vertical scars or horizontal scars or any scars. So look for scars, swellings, color changes, etc. So the first thing we have to notice the skin over the chest. For that we have to expose the patient and we have to observe in clear light. Then the second thing we have to note is the position of trachea, tracheal position. So tracheal position is important. Normally it is centrally placed. It is usually visible in a thin person, but may not be visible in an obese person. If it is visible, look for deviation. If it is deviated to the right or deviated to the left. So if it is deviated, either ways it is pathological. So look for visible deviation of trachea. Okay. Then the next thing you have noticed is the position of apex beat. You know the apex beat position. It is there is a physiological position for the apex beat, and apex beat correspond to the tip of the left ventricle. So look for any deviation, if it is visible or not. Look for if it is visible or not. If it is visible, look if it is shifted towards the left sternal border, or if it is shifting towards the left sternal border, if it is shifting towards the anterior axillary line. So two type of shift can happen in apex beat, towards the right and towards the left. So towards the right, shift can happen in the right side when right ventricular hypertrophy, and left shift can happen in left ventricular hypertrophy. So look for apex beat. If it is visible, look if it is deviate towards left or towards right. So that's about position of apex beat. Then another point is we have to note in inspection is movement of the chest. So movement of chest, basically we will term it as symmetry of chest. Symmetry is examined mainly in palpation, but visibly if there is any deviation or a change in the movement of chest, we have to note it. So movement of chest is also important. Two type of patterns of breathing also we can observe with this manner of breathing, that is abdominal type of respiration and thoracic type of respiration. Normally in male persons, the pattern of respiration is abdominal, and female patients, for patient, the type of respiration is thoracic. So in abdominal type of respiration, diaphragm is taking the main part. In thoracic type, in the intercostals are working more when compared to diaphragm. So a sudden change in the type of breathing may be pathological. For example, if there is a painful condition in the chest, the thoracic type of breathing can change to abdominal type in a female, and the reverse can happen also. Abdominal pattern of breathing in a male person can be changed to thoracic pattern of breathing if there is a painful condition in the abdomen. So look for if there is a change in the pattern of breathing, whether it is abdominal or thoracic. So that's about the manner of breathing. Then The next thing we have to note is the rate and depth of respiration. Then you know the normal rate of respiration is about 16 to 20 per minute, and the pulse rate is 72 per minute average. And there is a direct relation between the pulse rate and respiratory rate. The respiratory rate, with the ratio of respiratory rate and pulse rate is 1:4. That is usually increase and decrease simultaneously, or it is directly proportional. So sometimes the rate can increase at the cost of depth, or the depth can increase at the cost of rate. That's also important. Again, the same principle is applicable. If there is a painful condition in the chest, the rate is increased and the depth is decreased, or the patient will take short breath, but the number of breath is increased or the rate is increased. Similarly, if there is a some conditions which lead to the there is difficulty in breathing, something like that, or the patient may take slow deep breath. So in that case, the depth is increasing at the cost of rate. So you have to note the rate and depth of respiration. The rate is increased, it is called tachypnea. We can term it as tachypnea, and if the depth is increasing, we can term it as hyperapnea. So tachypnea and hyperapnea are important. So that's about the rate and depth of respiration. Then there are certain abnormal patterns of breathing also. Abnormal pattern, that's also is important. We can reach a provisional diagnosis depending on or noting this abnormal pattern of breathing. And the most important abnormal patterns are, first one is pursed lip breathing. Pursed lip breathing is mainly seen in emphysema. Here the patient voluntarily exerts a pressure inwards. So it looks like this. Like this. This is the pattern of breathing you get in emphysema. That is, and the next abnormal pattern is paradoxical breathing. Paradoxical means, from the word itself, it's a contradiction. So it happens in motor vehicle accidents when there is multiple fracture of ribs on the other side of the sternum. So it acts as a free part, it moves freely. So during inspiration, that part move inward and the rest of the chest move outward. That's a paradox. So it's against the normal. So that's why it's called paradoxical breathing. It's typically seen in multiple rib fractures. It's otherwise called flail chest or stove-in chest. It's a surgical condition, multiple rib fracture. So it's about paradoxical breathing. Then other patterns are chain stocks breathing and Biot's breathing. Chain stocks breathing means, again, it happens in some respiratory center affections or diseases affecting respiratory center and like that, or in narcotic poisoning like that. So here the intensity of breathing gradually increase, then reaches a maximum, then it will gradually decrease, and there is an area of apnea or cessation of breathing. Then the process again repeat, gradually increase, the intensity gradually increase, reaches a maximum, then gradually decrease, then there is a phase of apnea, and the process continues. And that pattern of breathing is called chain stocks breathing. And there is a similar pattern called Biot's breathing, and is classically seen in meningitis. Here the fluctuations are rapid fluctuation or changes in the intensity, and again the apneic phase is common. There is a apneic phase, then again the rapid fluctuations are there, and this happens in meningitis. It is called Biot's breathing. So it's about chain stocks and Biot's. Then gasping or grunting breathing is there. Here there is increase in the movement of air, or the velocity of air is increased, or breath is increased. Movement of air is more. It happens in physiological also, or for example, if the patient runs or doing some physical exercise, something like that, there may be gasping or grunting type of breathing. Then sighing type of taking deep breath over time, that is called sighing type of breathing. It happens in nervous subjects, etc. Then Kussmaul's respiration. Kussmaul's respiration happens. It's also a different pattern. Kussmaul's respiration. It happens in acidosis, especially diabetic ketoacidosis. It is slow, deep breathing. Slow, deep breathing with a narrowed lip. Slow, deep breathing. That is Kussmaul's respiration. It is typically seen in acidosis, especially diabetic ketoacidosis. So these are the abnormal patterns of breathing. Then finally, in inspection, you have to observe there is any change in the shape of the chest. That's also very important. In the infant life, there can be some changes associated with rickets. So in rickets, there are typical bony abnormalities. One is Harrison sulcus. Harrison sulcus is an horizontal groove running from the sternum outwards towards the axillary area. That is inward drawing of the lower part of chest is there. That is called Harrison's sulcus. That's a finding you get in rickets. Then there can be nodosities over the both sternal border or over the costochondral junction. There may be swelling of costochondral junction. That is called rickety rosary. It looks like a rosary, bead-like projections over both sides of the sternum. That is called rickety rosary. Then another manifestation in rickets is pigeon chest. Pigeon chest, or it's otherwise called pectus carinatum. Pectus carinatum or keel breast or pigeon chest, all are same. That is undue prominence of the manubrium sterni. The undue prominence of manubrium sterni can be called as pigeon chest, and it is typically seen in rickets. It's also seen in infantile or childhood asthma also. So it's both seen in asthma and also in rickets. So look for these changes, typical changes you get in rickets. Then there may be indrawing of the lower part of sternum. That is called funnel chest. Funnel chest. It is called pectus excavatum, or it's otherwise called funnel chest or cobbler's chest. Is usually seen in cobblers because of their peculiar posture. Cobbler's chest. Then it is seen as congenital, as a congenital condition also, maybe congenital also, funnel chest. So it is pectus excavatum. So pectus carinatum is pigeon chest, and pectus excavatum is funnel chest or cobbler's chest. Then there can be flat chest also. The anteroposterior diameter is shortened, leading to flattening of chest. That is called flat chest. It happens in advanced pulmonary fibrosis, fibrotic, or restrictive lung diseases, complications after tuberculosis, or advanced fibrotic lung conditions. That is flat chest. Then barrel-shaped chest is there. That is altogether there is a cylindrical shape or barrel shape. Here the anteroposterior diameter becomes equal to that of the transverse diameter, or the cross-sectional area becomes circular when compared to the elliptical shape in a normal person. So that's called barrel-shaped chest, and it is typically seen in emphysema, barrel-shaped chest. Then look for any abnormality in the spine also. So there can be forward bending of spine leading to appearance called kyphosis. Then lateral bending can be there. That is called scoliosis. All this can happen. So look for these changes, vertebral changes also in inspection. So these are the things you have to observe in inspection. So in short, you have to note the skin over the chest, then position of trachea, then position of apex beat, then movement of chest, manner of breathing, different pattern of breathing, then abdominal or thoracic type of breathing, then rate and depth of respiration, then abnormal patterns if any, then finally the shape of the chest. All these come under inspection of the chest.